well. Thank you for joining today. I'm Sally Sansom, and I'm a DPhil candidate here at the Health Economics Research Centre at Oxford, and I'm also a Junior Research Fellow at the Centre for Personalised Medicine at Oxford. My presentation covers my DPhil program of work, which is exploring the measurement of outcomes from genome sequencing for rare disease diagnosis in the context of economic evaluations. So, what are rare diseases? Rare diseases are conditions that are individually rare, but that collectively affect approximately 6 to 8% of the population. These conditions are associated with significant morbidity and mortality, and approximately 80% of these have a genetic cause. However, obtaining a rare disease diagnosis can take several years, and approximately half of all people with a rare disease remain undiagnosed. Thankfully, genome sequencing is changing this paradigm by improving the likelihood and the speed of obtaining a diagnosis for rare disease patients and their families. However, genome sequencing can also produce a range of positive and negative outcomes among patients and their carers. These outcomes have been demonstrated to span clinical, emotional, cognitive, behavioural, and social domains. This means that the outcomes from genome sequencing for rare disease diagnosis go beyond those typically measured by health economists in health technology assessments. In addition to this, even when diagnosed, many rare diseases have no available treatment options. So this means traditional outcome measures such as survival and health-related quality of life may be less relevant to assess in this context. However, we know from the literature that patients, carers, and clinicians still place a huge amount of value on using genome sequencing for rare disease diagnosis, which has raised concerns regarding the suitability of generic health economics outcome measurement instruments used by health economists. So this is a problem because if the instruments we use aren't suitable for this context, we're at risk of comparing all of the costs associated with genome sequencing against only a partial picture of the outcomes. And this may impact future funding decisions and therefore the efficiency with which healthcare budgets may be spent. So my DPhil aims to determine which patient and carer-reported outcome measurement instruments are best suited to measuring the outcomes from genome sequencing for rare disease diagnosis in the context of economic evaluations. My DPhil is structured into 4 main phases of work, and my presentation today will briefly cover the first 3 phases. In the first phase of my DPhil, I conducted a systematic literature review to identify the outcome measurement instruments that have been used to measure the outcomes from genome sequencing, unrestricted by context, disease area, and the validation status of the instruments. 36 studies were identified, and these used a total of 58 instruments, which met the inclusion criteria, and the most frequently used of those is on the slide. So the most commonly used were the multidimensional impact of cancer risk assessment and the hospital anxiety and depression scale. The included validated instruments were used on average 2 times each, with a range spanning 1 to 9 times. However, many of the included studies didn't detail their rationale for instrument selection. Of those that did, the most common reason was that the instrument was widely used and had been validated in other populations, but not in the specific population of interest necessarily. And other reasons included referring to the efforts of the Clinical Sequencing Evidence Generating Research Consortium in the US, which is undertaking efforts to standardize outcome measurement across the studies that they run, as well as references to the efforts of the FENEX toolkit, which is also looking to harmonize measures in this space. So of the included instruments, 5 genome sequencing specific instruments were identified and 2 have since been published. 5 multi-attribute utility instruments or generic health economics instruments were identified as having been used in this context. 3 of these are designed for adults and 2 are designed for children. However, as you can see, very few of the included studies use either of these types of instruments. For genome sequencing specific instruments, this is likely because many of the instruments are still relatively new. Whereas for generic health economics instruments, this is likely because the instruments were determined to either be too blunt to detect changes in outcomes or not broad enough to measure all of the outcomes of interest. So following the systematic review, I then critically appraised the instruments identified by assessing their relevance, comprehensiveness, and feasibility within the context of genome sequencing for rare disease diagnosis. In doing so, I also included generic health economics instruments and carer-specific instruments that were identified as having previously been used in this context. Relevance and comprehensiveness was assessed by mapping each question in all of the instruments to the subdomains of an established model of patient and carer-perceived utility, which was developed by researchers at Harvard. As expected, the outcome domain most commonly measured is the instrument by the instruments was the emotional utility domain. However, it's also important to assess the feasibility of these instruments, and these considerations include the total number of questions asked by the instrument. For example, the AQUAL 8D has 36 questions, whereas other instruments such as the MHI5 has only 5 questions. So the importance of this will differ depending on the target population, as well as the other instruments and questions that are being asked in the study, which will also contribute to respondent fatigue. The next factor to consider is licensing costs and restrictions. Instrument licenses can be expensive to obtain, and although they sometimes have discounts for researchers or students, sometimes they're also offered for free. This is not always the case. And even if a license is free, it can still take a long time to organise the licensing, depending on the capacity of the legal teams in both of the organisations. Another factor to consider is whether the instrument you want to use is available in all of the languages that you wish to administer it in. And if this is not the case, whether the licence for the instrument imposes specific translation requirements. This is particularly important because translating instruments can be very expensive, and this is even more so the case if the translation required is that of a validated process, which can take many months to complete. The results from my critical appraisal have allowed me to determine the instruments with the greatest theoretical capacity to measure the outcomes from genome sequencing for rare disease diagnosis. This has informed the design of my prospective cohort study, which involves collecting data pre and post exposure to genome sequencing for rare disease diagnosis. This study will allow me to assess the content validity, construct validity, responsiveness, interpretability, acceptability, and feasibility of the instruments which I've included in my study. And these are 4 generic health economics instruments, including the EQ5D5L, the EQ Health and Wellbeing Short Form Index, and the AQUAL 6D, as well as the Quality of Life 15 Dimensions questionnaire. 3 genome sequencing specific instruments, including both patient and carer response models, which include the GeneU scale, the personal utility scale, and the factor instrument, as well as 1 generic psychological instrument, the MHI5, and 1 carer specific instrument, which is the carer quality of life instrument. So it's important to note that my study design was informed by consultations with over 40 professional stakeholders, including many from within the NHS Genomic Medicine Service, the GMS Research Alliance, and PPI representatives. And I've also obtained funding to support translating the participant-facing materials into Urdu and Punjabi, as well as having interpreters for these languages available during the participant interviews. The funding will also cover making both paper and digital versions of the study materials available to participants, as well as having a proxy pathway so that carers of people undergoing genome sequencing who are unable to participate in the study themselves for reasons such as intellectual disability can still be represented. And I'm also able to support funding NHS GMS genomic practitioners to refer participants into my study, which is excellent as this is the main source of genome sequencing within the UK. So what will this work enable? Once complete, this will hopefully help researchers, policymakers, reimbursement bodies, and other decision makers to make improved instrument selection decisions in the context of economic evaluations, as well as to have an improved understanding of where generic health economics instruments may fall short in this context, and how best to interpret the evidence that is generated using these instruments. So before I conclude, I'd like to acknowledge the contributions of all of my wonderful supervisors who are listed on the slide and who I'm very grateful to be working with, as well as my funders, the Nuffield Department of Population Health, the Clarendon Scholarship, and the Somerville College Mary Somerville Scholarship.